Hello, and welcome to the DBCC Breast Cancer Annual Update for 2021. My name is Rishi Sawhney. I am a hematologist and medical oncologist at Bay Health Cancer Institute, and I also serve as the medical director here at Bay Health. And I am very pleased to be invited back to discuss with you all today certain issues relating to long-term outcomes in breast cancer survivors. And this is actually an issue that oftentimes will fly under the radar, as we deservedly so put a lot of focus and attention on the immediate diagnostic and management strategies for women and men with breast cancer. But as we'll see over the next 15 to 20 minutes, there are a number of emerging issues that face long-term breast cancer survivors, and we're going to focus on just a couple of them today. So I thank you all for your attention today, and I hope you find this discussion enjoyable and informative. So why does breast cancer matter? Well, it matters to everyone who has logged in today for varying reasons, but it's also one of the, if not the most prevalent cancers in our country. And in fact, the latest statistics were just released for 2021 over the last several weeks and demonstrate that breast cancer continues to be the most common cancer identified in women in our country, with over 280,000 cases, comprising 30% of all female cancers. And unfortunately, breast cancer continues to be the second deadliest cancer in females, with over 43,000 estimated deaths, comprising 15% of all cancer-related mortality in women. So it remains a very important and prevalent problem in our communities. We do have some good news, though, and that is that there has been significant progress in the outcomes of women with breast cancer over the last several decades. And so additional statistics that were just released for 2021, if you look at the graph here on the right, demonstrate that the majority of cancers, each of which is demonstrated by one of these lines, the mortality or death rate is going down over time. And I'll draw your attention to the pink line here, because that is female breast cancer. And you can see over time, the mortality rate, after having been steady for a while in the mid-1900s, has really dropped over the last 3 to 4 decades. In fact, the risk of a woman dying from breast cancer has dropped by 1/3 over the last 4 decades. So that's very encouraging, and it's due in large part to advances in all of the different components of breast care that you see here, including risk assessment and genetic counseling to identify at-risk populations, healthy lifestyles and prevention, better screening and early detection, advances in surgical and radiation techniques, molecular testing, some of which we're going to touch on today, and advances in various types of systemic therapy for breast cancer, including targeted and immunotherapies, and of course, continued improvements in supportive and palliative care. And so what all of this has created is a growing number of breast cancer survivors. In fact, there are now estimated to be 3.8 million women living with breast cancer in the United States, with a 5-year survival rate for early stage breast cancer of 91%. And a 15-year survival rate of 80%. So this is really a growing population of women, and that's a good thing. But it also opens our eyes to a new set of challenges that these women may face going forward as they move on from their diagnosis and initial treatment of breast cancer. And there are a number of survivorship issues, if you will, that women may face and that we talk about in our clinics. And it can range from psychosocial and cognitive and financial, and dealing with late side effects of therapy and integrating back into the workplace, and a number of different issues. But I would say consistently the two concerns that are at the forefront of most of my patients' minds as they move on into survivorship mode are concerns about a potential late recurrence of their breast cancer and concerns about a new or second primary breast cancer. And so these are really the two issues we're going to focus on over the next few minutes. Now, a late recurrence of breast cancer, we're primarily talking about a distant metastasis, which can be in virtually any organ in the body, as you see here. And a new or second primary breast cancer could be in either the same breast or in the opposite breast, and typically will be a different cancer that might have different receptors. And the two questions that I hear most consistently from my survivors are, what is my risk of these things happening? And what can I do to lower my risk? And that's really the essence of our conversation today. Understanding the risk of these late potential issues and how we might be able to lower the risk. So before we dive into that, a quick refresher, reminder to all of us, breast cancer is not one disease. The details do matter. You must know your subtype. And there's different ways to classify this, but for the sake of simplicity, we're going to consider three main subtypes of breast cancer. Those that are estrogen positive, which is about 70%. Those that are HER2 positive, which is about 15 to 20%. And those that are triple negative, meaning negative for estrogen, progesterone, and HER2 receptors, which is about 15%. Each of these subtypes of breast cancer has its own unique biology, clinical behavior, natural history, and management strategies. And speaking about differences in natural history, this point is going to be very important to our subsequent discussions, and that is understanding what is the natural history of these different subtypes of breast cancer. And so this graph here demonstrates over time a woman's chance of being alive and in remission with various subtypes of breast cancer. And so as you can see here, at time 0, every woman is in remission. Over time, the lower the line goes, the more women are relapsing from their breast cancer. And I'll call your attention to two specific lines, and that is the orange and the purple line. These two lines, as you see here, represent breast cancers that are estrogen positive. And what you can see is with these two lines, they never really level off, which means women continue to relapse beyond 5 years, 10 years, 15 years, up to 20 years. These two lines don't really level off, as opposed to all of the three types that are estrogen negative. Those lines tend to level off after about 5 to 7 years, suggesting that once you get past that point, the vast majority of women are no longer relapsing. So differences in the natural history, which are going to be important. Taking this concept a step further, an analysis of various studies that was done back in 2011 that looked at what happened to women who were treated with adjuvant tamoxifen versus those that weren't. And certainly adjuvant tamoxifen provided significant benefit and more women survived, and that's been known for a while. That's not the point of what I'm saying right now. But what was realized is that if you look here, this graph is showing the percentage of patients that were alive and remained in remission. And similar to the last graph, you can see that over time with estrogen positive breast cancer, it is gradually trending down. It doesn't really flatten out. But the remarkable point here is if you look at it, overall, the chances of a woman relapsing with estrogen positive early stage breast cancer are relatively low. But if a woman is going to relapse, there's about a 50-50 chance whether that will happen before year 5 or after year 5. And that's remarkable. So if you think about it, once you get past year 5, there were still 17% of the relapses that occurred versus 15% before year 5. Again, understanding significant risk of delayed relapse beyond 5 years with estrogen positive breast cancer. Taking it even a step further, this was a landmark analysis that was published in 2017 that looked at thousands and thousands of women with early stage breast cancer and asked the question of what happens from years 5 to 20 in particular, and looking at their rate of a distant recurrence. And here you can see over time the chance of a woman having a distant relapse. And it's broken down by women that had breast cancer that was lymph node negative, that had a few positive lymph nodes, or that had a lot of positive lymph nodes. And as you might expect, the more lymph nodes you had, the higher the risk of a relapse was. Women that had 4 or more lymph nodes positive had a 52% chance of relapse overall. But if you look at this, so many of these relapses are happening after year 5. So the whole point here is there is certainly no 5 years in the clear rule with estrogen positive breast cancer. This is looking at splicing the same data in a little bit of a different way. And I wanted to include this graph just to highlight the point that even for those breast cancers that seem to be the lowest risk and the most innocent, if you will, T1N0, less than 2 centimeters with clear lymph nodes, even in those cases, after year 5, 13% of women had a distant relapse after year 5. And that's pretty striking. And so it tells us that we must take all estrogen positive breast cancer seriously with respect to risk of a distant relapse. So how are we trying to combat this? What are we doing about this prolonged relapse risk beyond 5 years? Well, certainly we have very effective anti-estrogen medications, tamoxifen, and then various aromatase inhibitors, all of which have been approved for use in the adjuvant setting to lower a woman's risk of a recurrence. And up until I would say probably about a decade ago, the standard of care was 5 years and then you stop. And then various studies have been conducted after we understood the risk of a late relapse and looking at, well, is 10 years better than 5 years? And if so, 10 years of what? Do we do 5 years of tamoxifen and then 5 years of an AI? Or do we do 2 years of tamoxifen and 5 years of an AI? Or do we 5 of tamoxifen plus 5 of tamoxifen? Or do we do 5 of an AI and then 5 more of an AI? And you can see here a summary of many, but certainly not all, of the various studies that have looked at these different strategies. But the bottom line is looking at 5 years of therapy versus more than 5 years of therapy. And these are all very important studies. And I've highlighted probably 5 of the landmark studies in this regard that included multiple thousands of women. And the bottom line being that there is definitely benefit for extended endocrine therapy beyond 5 years. And here you can see that women who are treated with 10 years of endocrine therapy, and I'm not being specific about which drug here, 10 years of endocrine therapy versus 5, there was about a 3 to 5% absolute benefit in terms of protecting these women from recurrences or relapses. So the benefit was there. It was statistically significant. It was modest. We're not talking about a 10 or 15 or 20% benefit here, but there certainly was a benefit of 10 years versus 5 years. And so the pendulum swung over to at least considering 10 years of therapy for the majority of women after they completed their initial course of endocrine therapy. So it would seem like it's an open and shut case, right? Give 10 years of therapy to all, but what is the cost of doing that? What is the cost of extending this treatment beyond 5 years? Well, certainly there are various side effects associated with anti-hormonal agents. And these can vary from what I loosely term as annoying side effects that might impair a woman's quality of life, like vasomotor symptoms, hot flashes, fatigue, joint pain. And it can range all the way over to more severe or potentially serious symptoms such as skeletal fracture and rare risks of blood clots or venous thromboembolism and uterine cancer, particularly with tamoxifen use. So we must take these drugs seriously. And in fact, the question becomes, well, if you extend to 10 years versus 5 years of therapy, are you making these side effects worse? And there was a fairly large analysis that was just published in 2020 that actually suggests that of the various side effects that women may get from these drugs, some of them don't change with 10 years versus 5 years, and some of them increased with 10 years versus 5 years, as you might expect, including cardiac toxicity, bone pain, osteoporosis, bone fractures, joint pain, muscle pain, and hot flashes increase with 10 years versus 5 years. Again, this is kind of intuitive, but it was shown with evidence to back it up. So there's increased toxicity with 10 years versus 5 years. And what happens when there's increased toxicity? Well, sometimes women stop taking the medication. And this graph here shows you a summary of several different studies that suggest to us that by the time you get to the 4th year of a woman taking one of these anti-hormonal drugs, whether it's an AI or tamoxifen, there's about a 40 to 50% chance that they are not taking the drug consistently daily the way that they are intended to. And it's usually because of these side effects. And as you might expect, drugs don't work if you don't take them. So while the 10-year versus 5-year is great, and it's great to improve outcomes for 3 to 5% more women, there is some cost in terms of toxicity and side effects that leads to some women not taking the medication. So the million-dollar question from my perspective is, how can we be smarter about who truly needs extended therapy? If there's a 3 to 5% absolute benefit, which I've shown you, that means for every 100 women that we extend their treatment out to 10 years, we're going to help 3 to 5 of them. And what about the other 95 women that are getting exposed to extra side effects, but not really getting the benefit? Can we better predict who might get that benefit and reserve the therapy, the extended therapy, just for those women? And to get to this question, we really need to understand the difference between prognostic and predictive. So prognostic factors or markers really look at evaluating the progression of a disease over time with or without treatment, or irrespective of treatment. And it helps us understand what's a patient's risk of recurrence. And we typically use clinical and pathologic factors in breast cancer to understand prognosis, such as the tumor size, the lymph node status. And as I showed you in some of the earlier graphs, certainly the risk of late recurrence went higher with more lymph nodes involved or with a larger tumor. So this makes sense. This is not anything groundbreaking or new. There are selected genomic assays that can help us with prognosis. Oncotype is one of them in some regard, and there are certainly others as well, as we'll go over. But really, the essence here in trying to understand how we can better select women for treatment or extended treatment is predictive markers. And so a predictive marker assesses the most likely response to a particular therapy. And it helps determine whether a woman is more likely to benefit from that therapy. So if we look at our scenario here with women, prognostic factors look at what is her risk of a late relapse. Predictive factors look at what is the likelihood that taking extended endocrine therapy will lower that risk of a late relapse. And while we can use clinical factors to assess prognostic information, clinical factors have been proven to not really be very helpful in terms of predictive information. And in fact, the only tool that's been proven to this point is genomic testing. And that's really what we're going to dive into now. So just a quick refresher on genomic testing. Genomic testing really looks at testing the genes and DNA of a particular cancer or of a particular cell line to look for changes that might either increase the risk of developing cancer or explain why a tissue has developed into cancer and what's driving that cancer growth. There are two broad types of genomic testing. There's hereditary testing. This is testing germline DNA that one is born with and carries their whole life and passes along to their children. This is being used at this point to identify at-risk populations for prevention and early diagnosis. BRCA testing is a classic example here. On the converse, the second type of genomic testing is what we refer to as somatic testing, which is testing not of your hereditary DNA, but of the DNA of the tumor. And this is looking for mutations that you were not born with, but have acquired at some point during your life and do not pass along to your offspring. And this genomic testing is very useful in people that have already been diagnosed with cancer, either in early stages to help us with prognosis and predictive information, or in advanced stage disease to help us select targeted therapies that would attack specific mutations. So two main types of genomic testing. We today are talking about somatic testing of tumor DNA in early stage disease. And in fact, there are multiple genomic tests that are now out for hormone receptor positive breast cancer, including the Oncotype, which we mentioned, which is widely used now in early stage breast cancer at the time of diagnosis to help us understand who may benefit from adjuvant chemotherapy. And then the breast cancer index is really the one I'm going to focus on now, which is a genomic test that is used to understand a woman's risk of a late relapse and to predict, there's that word, predict, who may benefit from extended endocrine therapy. So if we think about the breast cancer index, the Oncotype, which again, many of us have familiarity with, is an assay of 21 genes that helps us predict who may benefit from chemo or not. Well, similarly, the breast cancer index is a compilation of 11 genes that helps us predict who may benefit or not from extended endocrine therapy. The Oncotype would be done at the time of diagnosis. The breast cancer index would typically be done at the time a woman is reaching her 5-year mark of anti-hormonal therapy. And you're trying to decide, should we continue to 10 years or should we stop at 5 years? There are two main biomarkers that are looked at and reported by the breast cancer index. And so we're going to make this simple. There is the BCI prognostic, which helps us understand what's this woman's risk for a late recurrence. And then there's the BCI predictive, which helps us understand what is the likelihood that extended endocrine therapy is going to lower her risk of a recurrence. And this BCI predictive is based upon a specific gene ratio, which you see here, HOXB13 to IL-17BR, which we're now going to refer to as the HI ratio or BCI high. This is an example of the report that the breast cancer index can show us. And it really just makes it simple. It gives us two main pieces of information. The first is, what is the likelihood of a late distant recurrence beyond 5 years? And the second piece of information is this woman, this particular woman, based on the study of her particular genes of her tumor, is she likely to benefit from extended endocrine therapy or not. So let's look at some of the data that helped us believe we can trust this tool, this genomic tool. So first, BCI prognostic. This is just looking at the risk of a late recurrence. Well, as I've shown you before, we can get pretty good at understanding this based on tumor size and lymph node status and so forth. But here, let's look at what the genes do for us. And so a compilation of several large landmark studies shows us that in terms of prognosis, the BCI breaks women down into two groups: BCI low risk, where their risk of a late recurrence is only 2 to 3%, and BCI high risk, where their risk ranges anywhere from 9 to 16%. Again, this is from years 5 to 10. So it looks like it's pretty good at separating these women into two groups. And while that's very helpful information for me and my patients, this alone doesn't tell me if extending their endocrine therapy is going to help them. What does tell me that is the BCI predictive. So this is the second part of that algorithm. And so with the BCI predictive, there are a number of studies that have really supported the effectiveness of this tool. I'm going to highlight just a few of them briefly. So one of them was a look back at the landmark MA17 trial. This was a trial from years ago that looked at after 5 years of tamoxifen, randomizing to 5 years of letrozole or placebo. And so when researchers went back and looked at the patterns of the women who got letrozole versus placebo and the women who relapsed versus the women who didn't, and looked at these BCI gene analyses, they found that, first of all, about 60% of women came back showing a low HI ratio, or BCI low, which meant about 60% of women had a low likelihood of benefiting from extended endocrine therapy. And about 40% had a high HI ratio, or had a high likelihood of benefiting. Now, for the 40% or so that had a high BCI, there was a dramatic benefit from those women taking 10 years versus 5 years, a 16.5% absolute benefit compared to 3 to 5% for the overall population I showed you. So if you're at the 5-year mark of endocrine therapy and you get a BCI high score, it's very likely that taking another 5 years of endocrine therapy is going to help you. However, if you have a low BCI score based on the genes of your tumor, it is unlikely that additional endocrine therapy is going to make any difference. There was no benefit in this study in women that had a low BCI score. This is, again, helping us predict the endocrine sensitivity of each woman's individual tumor. Now, I've just shown you that this HI score was very predictive. It helped us understand who may benefit, and a high HI here in red was very likely to predict benefit. But guess what was not predictive? Tumor stage, estrogen status, lymph node status. So even though these things seem like they should help us understand who should take 10 years versus 5, based on this study, whether a woman had positive lymph nodes or not really didn't predict if they were going to benefit from 10 years versus 5. But changes in her genes did. Let's go to a second trial briefly, the TransAtom trial. This trial looked at 5 years of tamoxifen versus 10 years of tamoxifen. And this really, there was a retrospective analysis of this that looked at BCI, focusing on lymph node positive patients. And here's a similar story. For those women that had BCI high, there was a substantial benefit from taking 10 years versus 5 years. The benefit that you see here was about 10% versus 3 to 5% in unselected cases. And if your BCI was low, it really didn't help you to take 10 years versus 5 years. Their risk of recurrence at year 15 is the same either way. And so those women with BCI low don't benefit from the extra 5 years of endocrine therapy. They just get the side effects, according to this analysis. And then the third trial is the IDEAL trial. This is the most recent. This was just updated at San Antonio Breast Conference in December 2020. And this study looked at tamoxifen or an aromatase inhibitor, or tamoxifen followed by an aromatase inhibitor, but either way, 5 years of endocrine therapy, and then randomized to either 5 more years of letrozole or 2.5 years of letrozole. And so what researchers did in this case is they used BCI to go back and look at 10 years total of endocrine therapy versus 7.5 of endocrine therapy. And again, we see a similar pattern. If women had a low BCI score, they did not benefit from longer endocrine therapy, 1% absolute benefit. However, with a high BCI score, there was a substantial benefit. You can see how wide apart these curves are, a 12% benefit from taking longer endocrine therapy. So stating in a different way, with a low HI score, there's no benefit to additional therapy, only toxicity. With a high HI score, there is substantial benefit to additional endocrine therapy and reducing a risk of a late relapse. Splicing the data from the same trial a different way, I'd like to highlight a couple of additional points. Look at women from this trial that had high risk disease based on clinical and pathologic features, lymph node positive, big tumors. Some of those women had a low BCI score, and there was no benefit from extended therapy. So even though on the surface, this looks like a high-risk tumor, you need to take 10 years because your nodes are positive, if the genes tell us that the tumor is not endocrine sensitive, then 10 years is no better than 5 years, according to this study. Conversely, tumors that are small and lymph node negative, grade 1, innocent appearing tumors, if their BCI score was high, there was substantial benefit from extended therapy, 12% benefit. And this is a patient who, if you just looked at their tumor size and lymph node status, you might say, oh yeah, they can stop at 5 years. They don't need extended therapy. Their tumor looks very innocent. Not if the genes say otherwise, according to this study. So summarizing some of the key trials on looking at predictive value of BCI, these are the ones that I've covered. And the bottom line is that if you look at all 3 trials, there was remarkable consistency in their reporting, and actually 4 trials here, which is that for women that had BCI high scores, if they continue extended endocrine therapy, they had about a 65% relative risk reduction in a late relapse. That's very powerful. And it makes sense because what the BCI score is telling us is these women have endocrine sensitive tumors. That's what the genes they're studying tell us. And there was substantial benefit in those cases. If you have a tumor that looks high risk on the surface, big tumor size, 3 positive lymph nodes, but it's not endocrine sensitive, then it does not appear that it benefits them to continue taking endocrine therapy beyond 5 years. It just gives them more toxicity. So I think going forward that genomic tools like the BCI are going to be an important piece, but certainly not the whole picture, an important piece of our decision-making algorithm. And there was a very interesting, albeit small study of about 100 patients from Yale that looked at how the BCI impacted clinical decisions. And so it was a questionnaire-based study where they questioned doctors' plans regarding endocrine therapy, and then they also questioned patients regarding anxiety and conflict. And what they really did is they asked physicians, when a woman's completing 5 years of therapy, based on pre-BCI, without the BCI score, what was the doc's intent? Continue extended therapy or stop? And then they had these women get a BCI and then went back and asked the doctor if they changed their mind or not. And then they asked patients about their anxiety and level of conflict. And the bottom line is that what a physician was originally planning to do as far as extended therapy changed about a quarter of the time after they interpreted the BCI results. Again, a tumor that might look one way on the surface, but actually is biologically appearing to be a different way. And then there was a net decrease in extended endocrine therapy from 74 to 54%. This is huge. We are lowering the number of women that are being exposed to a potentially toxic therapy because it's unlikely to benefit them. And that is just as meaningful to me as finding a new drug that improves survival in a population, is being able to tailor therapy to reduce toxicity and improve quality of life. It's the essence of what precision medicine really is. And there was a decrease in conflict and patient anxiety. So if a woman finishes 5 years of endocrine therapy and she's torn, she doesn't really want to continue the medicine, but she's worried if she stops it, she's going to be hurting herself in the long run because she may have a higher risk of a cancer relapse. Having a low BCI score arms her with some confidence that she's making the right decision. And so what's come out of all of these different studies is recognition and acceptance by the NCCN practice guidelines. And I think this is huge. And I think this is going to lead to increased use of genomic testing for predicting a benefit from extended endocrine therapy. And as you can see here, the breast cancer index, this is the latest version of the NCCN guidelines from 2021. The BCI is now predictive for benefit of extended endocrine therapy and has earned a category 2A level recommendation, which is the same level of recommendation as the use of Oncotype for lymph node positive patients, which is something that many of us are now doing fairly routinely, particularly for women with limited node positive disease. And so this has a pretty good backing at this point. And the NCCN goes on to describe further details, which is really a summary of what I've just gone over with you on how you interpret BCI low and BCI high scores and some of the data that led to these interpretations and conclusions. So how do we put it all together? So you are, or you're taking care of a woman who is coming up on her 5-year mark on adjuvant endocrine therapy, and that big decision is looming. Do we continue or do we stop? So, as I mentioned, the genomic testing is very valuable, but it's just one piece of the puzzle. We must take a global view of our patients. We must assess, are they tolerating it well? Do they have good bone health where they could tolerate further endocrine, particularly aromatase inhibitor therapy? Did they have high-risk clinical and pathologic features? I've shown you that that doesn't seem to be very powerful in predicting benefit to endocrine therapy, but certainly it's still something we keep in mind as part of our global assessment of how we treat our patients. And then genomic testing. Do they have high-risk genomic testing? And if they fall into this profile with some or all of these features, I would give them a green light and say continue beyond 5 years, particularly if they have high-risk genomic testing. However, who might we give a red light to say stop at 5 years and do not continue? Well, if they have low-risk genomic testing, I've shown you that a low BCI score suggests there's not significant endocrine sensitivity, and thus it appears to be minimal benefit from extended therapy. But furthermore, if they're having a lot of difficulty with tolerating the medication, if they're developing osteoporosis and you're worried about fractures, or if they have low-risk clinical and pathologic features, small node-negative tumors, although I've just shown you that you can't really look at that in a vacuum anymore. You must interpret that in conjunction with other factors, including the emerging role of genomic testing. So taking all this information and bringing it to our clinic, let's quickly look at a couple of cases. So there's a 52-year-old premenopausal woman who had a right breast cancer, stage 1, ER positive. And remember, this tool works only for ER positive women who are completing 5 years of endocrine therapy. So she had a lumpectomy, axillary evaluation. She had a low-risk oncotype. She did not receive chemotherapy. She was radiated and then took tamoxifen for 5 years. Did well, had a few side effects, but nothing major, hot flashes, a little bit of arthralgias. And now it's the 5-year mark and she's wondering what to do. So the breast cancer index is performed and it returns with an 8.5% risk of a late recurrence and a high probability of benefit from extended therapy. Remember, there's 2 components to this report: risk of late recurrence and probability of benefit from endocrine therapy. And so taking all this into account, even though her cancer was only stage 1, she was having a few side effects, she would have been fine if we had said stop it. But based on this genomic data, our joint decision and recommendation was to continue an additional 5 years of endocrine therapy. And of course, in addition to that, we would continue surveillance per NCCN, which includes clinical evaluations, breast imaging, and so on and so forth. A second case is a 66-year-old postmenopausal woman, left breast cancer, stage 2, node positive. And she had a left mastectomy and node evaluation. She had an intermediate oncotype recurrence score of 22. Technically, it's now considered low risk, but at the higher end of low risk. She had adjuvant radiation and received letrozole for 5 years. She did develop some osteopenia and mild to moderate joint discomfort. And so she comes to me and she's torn because she's having some difficulty with the medication, but at the same time, she understands that her cancer had high-risk clinical and pathologic features, and so she wants to do whatever she needs to do to try to protect herself from a late relapse. So her BCI was performed and came back with only a 3.5% risk of a late recurrence and a low likelihood of benefit from extended endocrine therapy. In other words, a low HI ratio. Therefore, even though her cancer on the surface looked high risk, based on the genomic tools, based on her tolerability and her personal preferences, a decision was made to stop endocrine therapy at 5 years. She was not felt to have an endocrine sensitive tumor, and thus continued endocrine therapy, if we were to believe the data, would provide much more chance of toxicity than it would of actual benefit or protection from a late recurrence. But of course, she would also continue surveillance, breast imaging on the contralateral side, and so forth. So that is a detailed discussion on one of the top concerns of our survivors, which is the risk of a late recurrence, and an introduction to emerging genomic tools that might really help us be smarter about selecting those women that are more likely to benefit from potentially very valuable extended endocrine therapy. I just wanted to close with a couple words on the other concern that women have with regards to cancer as late survivors, and that's a second primary breast cancer. So this is not the same as a recurrence. It's a new breast cancer that can come up either in the same breast or in the opposite breast, and the receptors might look the same or completely different from the original cancer. This is a real issue. It occurs in about 4% of breast cancer survivors. So 1 out of 25 breast cancer survivors will develop a second primary breast cancer. This risk is estimated to be about 0.5% per year in the standard risk woman, although it may be higher in those with germline gene changes such as BRCA, where it's 50 to 65% risk of getting a second breast cancer. This is the driving force behind why we recommend consideration of a bilateral mastectomy when a BRCA positive patient develops breast cancer on one side. But younger age is also associated with a higher risk of getting a second breast cancer. And we think it might relate to several factors, primarily differences in tumor biology. Younger women are more likely to get aggressive original cancers and more likely to be associated with germline gene changes. Women that had original ER and PR negative tumors are more likely to get a second primary cancer as well. As we mentioned, it can be ipsilateral or contralateral. And interestingly, about half of these second primary cancers occur after 5 years out from the initial cancer. So again, delayed risk beyond 5 years. With a breast cancer survivor, we cannot and should not ever truly let our guard down when it comes to monitoring for these potential issues. Appropriate follow-up is crucial, therefore. And so what must we do to be on the lookout for second primary breast cancers? Risk assessment, taking a detailed family history and identifying those women that may benefit from germline genetic counseling and testing. Careful history and physical examinations, breast imaging, mammogram plus or minus ultrasound, breast MRIs in selected higher risk women, and careful physical examination of reconstructed breasts, and occasionally imaging can be used there if there's a concerning exam finding. And then endocrine therapy is very important. I've just shown you how endocrine therapy can reduce the risk of a distant relapse, but endocrine therapy can also reduce the risk of developing a second primary breast cancer. And so this is one of the larger trials of extended endocrine therapy that was reported in 2016. And one of the pieces of data they looked at was when you take 10 years versus 5 years of extended endocrine therapy, what does that do to the risk of developing a new breast cancer on the other side? And the answer is it dramatically reduces that risk of developing a new breast cancer on the opposite breast. 3% of women versus 1% of women in those that received extended endocrine therapy. So realize that if you're taking extended endocrine therapy, and if you have undergone the appropriate evaluation to tell you that that's the right thing to do, which we now understand might include genomic testing, if you're doing that, not only are you lowering your risk of a distant relapse, but you're also lowering your risk of developing a second breast cancer. So in conclusion, key issues that are facing our growing number of breast cancer survivors include a risk of late recurrence as well as new second primary breast cancers. A late recurrence beyond 5 years is not at all uncommon, as I've shown you, in ER-positive, HER2-negative breast cancer. Extended endocrine therapy has been proven to decrease the risk of a late recurrence, but it can be associated with significant toxicities. Therefore, if we can get smarter and use not only clinical and pathologic, but also genomic tools to select those women with endocrine sensitive tumors that are most likely to benefit from extended therapy, that'll really be the key to optimizing outcomes. And then taking, by extension, those women that have endocrine insensitive tumors and sparing them from extended therapy that is unlikely to benefit them. And survivors are also at increased risk for second primary breast cancers and will benefit from ongoing regular surveillance as well as endocrine therapy, as we discussed. So with that, I will conclude my discussion. I thank you all for your attention. I know this is a very different format, and there's been a lot that we've all been dealing with over the last year, but I appreciate you taking some time today to learn about what's new and relevant in the field of breast cancer. We remain very committed to moving the field forward before, during, and after this pandemic, and I'm happy to take any questions in a format and forum that the DBCC has chosen. Thank you and have a great day.